Hi, my name is Ariel Singer, and today I'm going to be sharing a talk with you entitled The Healthcare Accompanist, Skills and Spirit for Person-Centered Screening and Referral. And as the title suggests, this talk will be focused on how we can offer people a patient-centered experience when conducting screening and facilitating referrals in healthcare and social service settings. Before I get into it, I'll tell you a little bit about myself and how I came to be focused on this subject. So when I first started my career, I worked as a health coach at a worksite wellness program where we used motivational interviewing to talk to people about their health. And a big part of that job was following up with people on their results from a health risk factor screening. And that experience of using motivational interviewing to talk to people all day, every day has really influenced my thinking about what a good experience looks like for offering screening and referral in healthcare. I did that health coaching job for a few years, and then I went on to, for the last decade or so, starting in 2010, offer technical assistance and training to mostly community health organizations in Oregon and around the country on whole person care and primary care transformation. And in that work, have led a bunch of different efforts to implement new screening approaches in healthcare, and have also offered training on person-centered communication to hundreds of community health professionals from different disciplines. So today we're going to be talking about screening and referral, and we're going to have a particular focus on social health screening. Although, as you'll hear as we go on, these skills and the concepts are really relevant across any type of screening and referral conversation, and are actually quite relevant across many different types of functional conversations you might have in a healthcare setting or social service setting beyond simply screening and referral. So I invite you to think about how you might connect the dots between this content and other types of conversations that you're facilitating with the people that you serve. So as I mentioned, we're going to be focused on social health screening, and we've heard people using different terms to talk about social health and the impact of social factors on people's health experience. And for a while, everyone was using the language of social determinants of health. And more recently, I think there's been a new recognition that the social determinants of health are these much larger social and economic conditions than what we can directly address in healthcare settings. So people are moving away from using the language of screening for social determinants of health and towards language like screening for social needs or social risk. What is really present for the people that we serve, and how might we respond to those immediate things, recognizing that underlying those social needs or social risks, there are these social determinants of health, and underlying those, the systemic causes that drive the social determinants of health. So we are experiencing at this point in healthcare in the US a social health tsunami. This has been a rising tide for quite a number of years now. And as of last year, almost half of our state Medicaid agencies had to establish some kind of requirement for social health screening in their managed care organization contracts. The National Committee for Quality Assurance has integrated requirements relating to social health screening into their patient-centered medical home standards, and has recently also established a new social needs screening metric as part of their HEDIS framework for health plan quality. The Joint Commission also has newly released standards for social health screening as part of a larger strategy to address health disparities. And in your state of Tennessee, TennCare, your state Medicaid program, has the Health Starts initiative, which has a few different elements to it, but is also focused on trying to more systematically address the non-medical risk factors that the Medicaid members in Tennessee face. So just some context for why is this a big deal? Why are we even talking about this now? It is becoming more and more widespread as a requirement in healthcare. So that I think requires us to think about how to do it well. So we have over the summer a new report published on the state of the science on social screening in healthcare settings, published by the Social Interventions Research and Evaluation Network at the University of California in San Francisco, really one of the leading bodies of researchers on social health issues in the country. And in this report, they look at a variety of different aspects of social screening in healthcare settings, including most pertinently to our topic today, how do both patients and providers feel about social screening, and what does doing it well look like? What makes a difference to people's experience? So starting with patients, how do patients feel about social screening? So what we learned from this report is that patients do regard screening as generally acceptable, and that there is a correlation between trust and acceptability. So patients who have a higher level of trust in their healthcare provider find social screening to be more acceptable, and patients with a lower level of trust have a less likelihood to find screening acceptable. We also learned that people who report prior experiences of discrimination in healthcare settings also have a lower level of acceptability around social health screening. Some of the specific concerns that patients name include risk of stigmatization, and risk to their privacy or over surveillance. And the report also concludes that more research is really needed. And that's honestly a common conclusion throughout this report, that the field of research on these topics is quite early, and more rigor and more research is needed in all domains. So we also can learn a little bit about how providers feel about social screening. So what we hear from providers has similarities to what we hear from patients. Social screening is generally acceptable, but it requires us to be clear in our explanations, to provide assurances about privacy, and implement strategies to reduce stigmatization. We also hear from providers that a lack of community resources, the sense of why am I screening if I can't respond, can lead to frustration, and that there's less evidence on how frontline staff feel about social screening. But we know that for providers, having educational or training experiences on how to do screening and referral effectively does increase provider confidence and readiness. At the same time, that kind of communication training doesn't address all of those workflow concerns, or that ongoing concern that I know I hear all the time, where people are quite concerned about screening for something for which they can't offer any assistance. So where there's a lack of social services or inadequate level of resources, people really express a lot of concern about doing screening in those cases. And we'll come back to that question as we go through our time together today. So another big topic that is experiencing a tsunami moment in the healthcare marketplace today is value-based healthcare. So I think it's useful to take a minute to think about what the connection is between screening and value-based healthcare. So here on this slide, we have a diagram describing a strategic framework for value-based healthcare. The first author on this article, Elizabeth Teisberg, was one of the original authors with a co-author on the book that kind of opened this era of value-based healthcare in the US, and is a very credible thought leader on this subject. So I think her strategic framework is a great place to look. So what you can see is this series of concentric circles describing some of the different tactics that we need to employ in order to implement a value-based healthcare strategy. And one of the things that I want to point out is that at the core of this set of concentric circles is understanding the shared health needs of patients. And when we think about, well, how can we go about understanding the shared health needs of patients, the answer is to ask them, which really means screening. we have to understand what's going on for people in order to be able to undertake this next series of steps in the strategy. So designing solutions to improve outcomes, creating and integrating learning teams, measuring the effect, expanding partnerships, all of that starts with understanding the shared health needs of patients. And what she's really describing here, or she and her co-authors are really trying to think at the population level. So not just thinking about what are the needs of the individual patients that we serve, which we have to find out by screening, but also how does that roll up to a population perspective. So at the heart of value-based healthcare is understanding what's going on for patients. So at the core of value-based healthcare is screening. So all that is to say that social health screening is here to stay. And so I think it really is incumbent upon us to figure out then how can we do this well? And how can we create an approach to social health screening that works really well for all of the people involved, both the patients that we serve, the communities that we serve, and the providers and staff who are being asked to conduct these screening processes. So I want to also here come back to the statement that I made that although we're kind of framing this around social health screening, really these concepts and skills and strategies for creating a person-centered approach to screening and referral are relevant across all of these different kinds of screening that we do routinely in healthcare settings. And I think it's useful to look at them all together in this way because it both gives us the opportunity to recognize that there are quite a number of sensitive questions or topics that we might be discussing with people where people might have a fear of social judgment or some sense of personal risk in disclosing information. And we can also see just what the total volume is of questions that we're asking people. And all of these types of screenings, maybe you're not doing every single one of them in your particular setting, but these are all quite common. And there are many organizations that are doing all of these. So if we want to create an experience for people where they're being asked this litany of personal questions, where they are going to feel comfortable and safe disclosing their personal information to us, then it's really our job to create that type of experience where the level of trust is sufficient that people will really get honest with us about what's going on for them. And we really want to have all of our questions function that way rather than functioning as an interrogation and feeling like an invasion of privacy for the people that we're hoping to partner with. So, of course, in order to really have an effect with screening, we have to not just do the screening itself, but we also have to think about what comes next. So what we're going to be talking about today is screening and referral, but I want to acknowledge that in order for screening and referral to really have the kind of effect that we're looking for at the population level, that really requires its own strategy. And I wanted to just acknowledge that and point you to one resource for thinking about population health strategy. This is from the American Hospital Association, their framework for population health. The link is at the top of the slide. And there's a whole lot of other ones that are available on the internet if you want to do some Googling about this. But I think a common theme is that you'll find is that there's implementation of screening and referral, and that requires a particular set of strategy. But then thinking about how we can maximize the effect on population health requires its own separate strategy and thought process, and usually requires a multi-domain investment in people, process, and technology, may require some additional health information exchange or community information exchange, good thought about the targeted clinical interventions that you will need to respond to population health issues. Got to keep the sustained focus on equity if you want that to be a factor in your population health solutions. Function with aligned incentives. That always makes a really big difference in driving system change. And of course, really thinking in terms of community partnership, recognizing that a lot of these issues that are influencing people's health and community level health are really driven by things that are happening outside of the walls of our healthcare delivery organizations. And so we have to be thinking in that community way in order to intervene effectively. So that's all important to acknowledge and to think about and to pursue resources on, and that is not what we're focused on today. Today, we're going to be really focused on the conversation and the environment for conducting screening and referral in healthcare and how we can offer people good experience. So I want to segue into that topic by introducing a metaphor, and this is based on personal experience from my own life as an amateur opera student. And this section of the talk is called Lessons on Accompaniment. And I offered in loving memory of my teacher who sadly passed away suddenly earlier this year, Mark Donovan Clark, who was an amazing teacher and mentor and had a really big effect on my life. So I want to start by inviting you to imagine that you are a member of a musical ensemble rather than a healthcare team. And of course, you want to put on a great performance. In the ensemble, there's all the players, but the patient is the diva, the pop star, the one who is at center stage. And the performance begins. And you and the other members of the ensemble are all playing your instruments how you were trained and brought up through your discipline to do. But there is a problem. Everyone's doing their own thing, and maybe they're doing it competently, but they're not unified in rhythm or tempo, maybe not even playing from the same sheet of music. Solving this problem, bringing everyone onto the same page, requires a shift in both mindset and practice style. You really have to rethink your role. With the patient at center stage, serving as the diva or the pop star, the role of the ensemble is that of accompaniment. So let's talk a little bit about what accompaniment means in music. So in music, the accompanist is there to support the principal part of the musical performance or composition. And what I have here on the slide is a quote from an article entitled, "What Makes a Good Accompanist?" And it's a description of what are the competencies and capabilities of the accompanist. So first of all, they must be supremely attentive listeners, very sensitive, really paying attention to the principal performer and trying to stay flexible and respond to whatever is happening as the performance unfolds. So much of this is relevant to how we can offer good accompaniment in healthcare settings as well, with attentive listening, flexibility, and calmness and adaptation being essential skills for a good healthcare accompanist. And I want to point out that being a good accompanist requires a lot of skill. You have to be an excellent musician, and then you also have to be good at all of these other things. So shifting to accompaniment is not about minimizing your role or your value as a professional. It's about shifting to a new paradigm and acknowledging that in order to collaborate successfully in this new paradigm, you may need to build a new set of skills that you don't have right now, or some new competencies, or maybe sharpening some of the skills that you do have to become a master in the art of collaboration. And then, of course, as a singer, you want to find the very best accompanist that you can. Mark, my singing teacher, always encouraged me to embrace the role of the diva, which as an amateur, as a student, I was hesitant to do. But he really encouraged me to recognize that it is the singer's job to set the tempo, to bring the artistry and the style, to lead the performance. And the very best accompanist will take your performance from good to great. So what I'll go on to talk about from here are some of the key concepts and skills for being an excellent healthcare accompanist, especially when it comes to screening and referral, and to think about what can take that experience from mediocre to good to great. And again, although our focus will be on screening and referral, these concepts and skills are relevant across many tasks and functions that you'll complete throughout your day. So in this talk, I'll be sharing with you this framework, collaborative screening, which offers the guidance for person-centered inquiry and draws on a bunch of different existing bodies of work, including motivational interviewing, trauma-informed care, empathic inquiry, cultural humility, health equity, as well as the input from a lot of stakeholders that I interviewed and conducted focus groups with to describe best practices for creating a person-centered approach to gathering information and following up with referrals in health and social service settings that's intended to elevate the perspective, the expertise, the autonomy of the individuals that we serve, rather than being primarily or exclusively focused on the needs and the requirements of our own institutions. So there's a few kind of big North Star ideas that guide this approach that I'd like to share with you before offering you a little bit more information about some of the details. So the first one is to recognize that risk factor screening does not equal whole person care. This is something that I have often heard people saying, that we want to offer people a whole person care experience. We're trying to improve population health. We have to do whole person care. And what they end up doing as a tactic for that strategy is implementing more and more different kinds of risk factor screenings. And I would make the case that describing risk factor screening as whole person care both reflects and reinforces a deficit orientation towards the individuals and communities that we serve. And that to offer good person-centered care, we really have to go from that deficit mindset where we're thinking about what's on the problem list, what are the risk factors, what are the issues that we need to fix for the people that we're working with, to relating to people in terms of strength and recognizing that we can't collapse people down to their issues and challenges and deficits and call it whole person care, that we have to see people as a whole human who is so much more than just their risks or their issues or their problem list, and begin to relate to them from a place of strength and perception of their strength and discussion of their strength. So the next big idea is that if we want to improve health equity, which is a common reason for initiating social health screening, we have to understand, connect with, and elevate the people that we serve, especially those with the greatest levels of distrust. So as we learned from the Siren report, people who have prior experiences of discrimination in healthcare or a lower level of trust as a starting point with their healthcare provider organization are going to be less likely to find our screening acceptable and to engage with us. So in order to address equity and to drive equity goals, we really have to reach those people. And to do that, we have to repair the ruptures to trust and earn people's trust, such that they see us as a partner and want to disclose information to us now. So the next big idea is an acknowledgement that relational care takes time, and that's what we're talking about here. Person-centered care requires building relationships. That takes time, and a little bit of time can go a long way when it is accompanied by heartfelt curiosity, respect for individuals, and some social emotional intelligence and skillfulness. A little bit of time can really make a big difference with respect to relational experience and connecting with people and understanding their needs. Lastly, I think it's important to recognize that when we set an agenda for what screenings we conduct, which questions we ask, this is an assertion of power relative to the people and the communities that we serve. And although there's an important role for system level priorities and strategies, it's not that we shouldn't have them, but we should also acknowledge the impact on the power dynamics and the relationship that our agendas have, and to recognize that we're going in with this whole long list of questions, and that's not why our patients came in to see us. Very likely they have their own issues and questions that they want to talk about, and we're the ones with the power and the relationship who are setting the stage for the conversation. And so really thinking about how we can reduce differences in power and relate to people as partners is going to be essential to offering a person-centered experience. So collaborative screening as a guidance model is screening tool agnostic. It is relevant to social needs screening, as we've talked about, to demographic screening, for example, asking people questions about race, ethnicity, language, disability, sexual orientation, gender identity, etc. Health behavior screening. So for example, asking people questions about drug and alcohol use, tobacco use, physical activity, sexual partners, etc., as well as conducting person-centered referrals across all of those domains. Collaborative screening offers both design principles and behavioral guidance for facilitating conversations and designing systems that are person-centered for conducting screening and referral. It offers detailed conversation guidance and implementation tools to support your implementation efforts, as well as a popular education-based training if you're interested in going deeper with this skill set. So now I'm going to go on to describe for you the collaborative screening design principles. And we'll start by just defining what are design principles. They are a set of values that act as a compass for your design process. So as you're figuring out what is our screening and referral strategy going to look like, both in terms of our workflows and our documentation and our team-based approach, as well as what any one person is doing to conduct a screening and referral conversation, all of that has to be designed. And these design principles can help you think about how to make choices as you go along and how to configure your approach such that it aligns with a person-centered experience. So there are two different sets of design principles, one relating to conversations and one relating to organizational systems. So we've already talked about some of these elements in person-centered screening conversations. For example, that first one is about recognizing and reducing differences in power, which we've already started to discuss. The second one is about prioritizing transparency, which is a practice from trauma-informed care that is another way of, again, sharing power with people. Knowledge is power. So the more that we can provide transparent explanations, the more we're including people in what's going on, giving them the information that they need to make choices and to feel at ease. And it both reduces the difference in power as well as increases psychological safety, so that there are fewer surprises for people, and that makes people feel safe. Demonstrating respect in our conversation is essential to, again, reducing differences in power and engendering trust. And focusing on strengths and recognizing that while people may face some challenges in aspects of their social health or health behaviors, that they also have strengths and assets that they're bringing to bear. And we can really enliven the conversation and demonstrate respect for them as human beings by talking to them about their strengths. And then finally, letting the client lead, letting them set the pace for the conversation, for how much information they'll disclose, et cetera. It's a way, again, of being a good accompanist and recognizing that the client this is their life and it is their choice about what information to share with us, and that Paradoxically, the more we defer to them on that, the more likely they'll trust us and want to share information with us about their experiences. So then, as a counterpoint, we also have to think about our organizational systems, because we might be offering people a really nice conversation, a really skillfully conducted conversation. But if the rest of our system around that conversation is at odds with the tone and style of that conversation, we're really kind of working, against ourselves in that way. So the more we can create alignment or consistency between our systems and our conversations, the better experience that the patients we serve will have. So again, the first one relates to raising awareness about both personal and organizational context and power dynamics. Healthcare is a very hierarchical sector, just even within the clinicians and staff who work in healthcare settings, and recognizing the power dynamics internal to the system, as well as the power dynamics between the healthcare professionals and the communities that we serve, is a good starting point for being able to start working to reduce those differences. There's also a variety of ways that we can create a welcoming environment, and from the very beginning, try to put people at ease and create that sense of relaxation and connection that will support them in disclosing information to us. Make internal and external partnership foundational to your strategy. So this is in terms of both implementation success, so using an interdisciplinary team to drive implementation within your organization, recognizing the contributions and insights of all the different members of the care team and the organizational stakeholders who might have some role to play in your implementation success, as well as, again, especially for issues relating to social health, taking a community and partnership-based approach to designing systems and responding to social health screening needs. As an organization, it's also very important that we demonstrate listening, not just in terms of within a conversation with an individual patient, are we listening, but also can we demonstrate as an organization that we're listening over time? So for example, setting up our documentation systems such that somebody can see and refer to information that was disclosed in a prior visit, so that we're not asking people the same questions over and over again. And then lastly, committing to consistency is essential for promoting psychological safety. The more we surprise people and catch them off guard, the more people will become guarded. And the more we can, across team members, across domains, across our workflow and our way of communicating, be consistent in communicating these principles to our patients, the more at ease and trusting they will feel. So if you want to learn more about collaborative screening, you can visit the collaborative screening website, which is collaborativescreening.com. Also linked at the bottom of this screen, a slightly longer URL, but it'll get you to the same place. And you can find there a whole bunch of free implementation tools, including conversation guidance tools with both really in-depth description of conversation guidance with sample language, et cetera, as well as more kind of at a glance versions, quick reference versions of the conversation guides. You will also find organizational systems implementation tools, including a really detailed compendium of the design principles and corresponding behavioral guidance, a quick reference version of that document, some implementation planning worksheets and resources. You can also watch a demo of a collaborative screening conversation and hear what it sounds like for yourself. And the thing that I wanted to end on is coming back to that concern that we hear from people about screening in the absence of sufficient social resources or referral connections that might be made. And the truth is that there are going to be times when we won't be able to respond to the issues that people are facing. And I wanted to share with you a quote from a community health worker program supervisor that I worked with in Oregon. And her maxim for her team was, even if we can't meet any of their other needs, we can always leave them feeling seen, feeling heard, and feeling respected. And that is within our control. We may not be able to control the sufficiency of social services in our community or the problems that our patients face, but we can influence how they experience their interaction with us. And we can make the choice to invest the time and effort to become a really skillful accompanist and to offer people a really high quality experience when we're asking them questions about their life, conducting screening, facilitating referral, and ensuring that that feeling of respect and companionship is always there. So I really encourage you to take a look at the collaborative screening website, check out the implementation tools, again, all available for free. And I'll end by sharing with you both the citations that were offered in the very early part of the talk, as well as the invitation to connect with me. So again, visit the website, send me an email, connect@arielsinger.com, or reach out to me on LinkedIn. I would be very happy to hear from you, hear your ideas about person-centered care, answer questions, or support your implementation in whatever way I can. Thank you so much for your time today.